Supriya Mannepalli, Medical Director for Infection Prevention and Control at Northeast Georgia Health System. And today in our podcast, we have Sarah Orstadius from our lab joining us. Thank you, Sarah, for
I'm
being
so
here.
excited. It's so good.
Yeah, I'm really looking forward to hearing what you have to share with our audience and me. And really just let's start with introductions.
Excellent.
What do you do in lab and how do you help us in caring for patients?
Perfect. Yeah. So I started my lab journey many years ago, apparently. I started at Michigan State University as a bachelor's in science in clinical laboratory science. From there, I started in a hospital clinical laboratory in the microbiology department at a hospital in Michigan. And then about 9 years ago, I transferred here to Northeast Georgia Health System. And it's been fantastic. I started in our microbiology area. For the last 3 years, I've actually been in laboratory operations, so overseeing a big part of our operations, but my microbiology is my love, and I just go back to it as much as I can.
And that's when I first met you in microbiology. We worked together on several initiatives related to infection control, antibiotic stewardship, and we can't forget all the partnership we've had through COVID.
Right.
Yes. And it's just that there's so many areas that we have worked together on, but I would like for us to talk about a few things. Really, the top one that comes to my mind is urine culture, diagnostic stewardship.
Yeah, so right now as our system, we're looking at those big initiatives and how we can drive down those CAUTI rates. And the laboratory partnered with you and our infection control team and just trying to figure out how we can help with that initiative. So we've helped to try to make recommendations in terms of best collection guides and getting those samples to us. We've partnered up to say, to make sure that tests are being ordered in appropriate manners and that everybody who is ordering these tests, especially from those patients that have a Foley placed, that they're being ordered properly for that and that everybody's aware of it.
And it's so important that urine culture is only obtained when it's clinically indicated. And we know, and it's evidence-based, that there's so many urine cultures that are obtained when they're not indicated. And anytime there is a growth of a bacteria, that's very tempting to treat with antibiotics. That leads to antibiotic resistance, C. difficile infection. So there are a lot of downstream side effects of the only time urine culture need to be treated in the absence of symptoms is if they're pregnant or if they're going for a urological procedure. You mentioned about collection. I know that's a huge problem, and that's also so important, that how the urine is collected is so important, right?
It really is. So for patients who can collect that sample themselves, it's really, really important to have those conversations with the patients for proper cleaning prior to that collection, that midstream clean catch collection. And that can be a hard conversation to have because you do have to talk about cleaning of private areas that people don't want to talk about. However, it's important to do that in this sense to make sure that we're getting the right kind of collection and we're not having contaminants with bacteria that's not actually causing infections. And then also to have those conversations with our nurses or other caregivers who are doing collections for the patient to make sure they're doing their cleaning processes correctly as well.
Absolutely.
That way we make sure that, all of that is collected in such a way that it's clean when it gets to the lab. Right. And then also in order to get to the lab, we need it to get to us in a timely manner.
Very important.
So as that urine is sitting there and that bacteria is in that urine, it has a doubling time. And we want to make sure we get it to the lab prior to that doubling time so we don't have an overgrowth of bacteria that's not significantly important for that. Once it gets to the lab, we can then process it or store it properly so that we can make sure that it gets set up so that it's significant for the patient.
And that is so important that we collect the urine properly, especially also in patients with Foley catheters. It's so important because the bacteria starts sticking to that Foley and that biofilm forms. So one, again, getting a urine culture from a patient with Foley, I always say, is synonymous to swabbing a dirty wound. It will grow something. So do not culture if it's not clinically indicated. But if really clinically indicated, patient has clear signs and symptoms of a UTI in a patient with a Foley, then always make sure you change out that Foley if no contraindications, and get it from that new Foley catheter and never collect it from the bag.
Right. Oh, absolutely. Yeah, we don't want that.
Yes.
And the lab, I mean, we're here to partner with you. We want to make sure that we're getting the right kind of samples. We're not trying to be the bad guys and saying, nope, just don't send that to us. Like we do enjoy the work. We just want to make sure that we're getting good results with the samples that are being sent to us.
Patients.
Correct. Yeah.
And when you say timely, how fast should we get the sample?
How fast? So definitely, we don't want it sitting on the counter for 2 hours. For urines in particular, that 2 hours is that doubling time for that bacteria. Really, once you label that at bedside, the sooner you can get it to the lab, the better. And we will process it as it comes in.
As it comes. And also, we also advocate for doing testing for a UA with a reflex culture when indicated, so that if the UA is negative, it does not reflex to the culture. And also, I know that several years ago, our lab updated the criteria when it will reflect to your culture, right?
Right. And partnering with the lab to make sure that that criteria makes sense and what our standards are. And then working with the different providers to say, this is what our criteria is and when a culture should reflex. That all is important. And that way, we're not getting phone calls to say, well, it doesn't indicate that we should, but I think I want it anyways. And we don't want to stop that, because there may be reasons where the clinician has a purpose for that. But really, we put those criteria in place for a reason. To kind of stop that process from happening.
Right, absolutely. I think one of the big criteria to reflex is presence of pyuria, which is more than 10 WBC as of now. But I know that's also something we're looking at to see if that cutoff should be higher.
Right.
Like some labs are even looking at changing to 20. So that's something we're also actively going to look at. Are there any situations where that urine will be rejected to culture?
I mean, absolutely. If we notice things where, maybe the collection time was so far off that, if it's over that 2 hours, 4 hours, we will be calling the floor and saying, we really need another sample for this. If we're getting cultures that have squamous epithelial cells in it that are just way high, it really indicates that it was not a very good collection of a sample, and there's a lot of skin flora in there. That would not be a good indication for culture, and we would recommend that that be recollected as well.
That's very helpful. Also, when the urine is set up for culture, sometimes we see that there's more than one type of bacteria growing. So do you always work up all of them if there is like 3 or 4, or you don't?
We really don't. So the standards that we follow, a lot of our guidelines come from different standards or different white papers or just guidance that the laboratory uses for references. And all of them that state in there are, if there is more than 3 organisms, you do not work that up. So we will work it up if there is 1 organism or 2 organisms. But once there's 3 or more, we put that out as a mixed culture. And that really is best practice for what we've seen and what the data shows.
Thank you. Yes, thank you for sharing that. That's very important. And is that also based on the colony count?
Yes. Yeah. We definitely look at those colony counts, but you're going to, if there's going to be a high colony count, like greater than 10,000 colony forming units, and there's mixed culture, that would be not an indication for us to work that up.
Okay. Got it. This is very, very helpful. There's so much work to do to reduce inappropriate urine cultures, both in the inpatient side and the ambulatory side. So thank you for your partnership on that. There's so many other areas we're working together. There are 2 things I do want to cover in the podcast. One is blood culture contamination. I know you're very passionate about that. You put in a lot of work, you and your team. So can you share something about that?
Yeah. So we have done a ton of work on this over the last over the last 4 years. We've done a lot of work on this. So the standards that are set is that the blood culture contamination rate should be less than 3%. And that is for your system as a whole, for both nursing collect and lab collect. And so we've done a lot of education to make sure that everybody is well-versed in how you should clean prior to blood collections. One of the really big changes that we've made in the last 4 years was the bringing in of a diversion device. And what the diversion device does is divert the first part of that blood. And it takes that skin plug that we, when you stick the needle in, you get a little bit of a skin plug, and it takes that and diverts it off so it does not go into that blood culture bottle. And that helps us to remove any of that commensal skin flora that might be on the patient's skin. And then we avoid calling that as a contaminant. We have seen our contamination rate drop dramatically with this. It's been a fantastic utilization in our system. We still have opportunities where we're trying to get people to utilize it more and showing them in the data, like, this is working, and we have a potential to achieve a contamination rate that's actually less than 1% if we continue on with this. So, and that's our goal overall, is to achieve that less than 1% contamination rate.
And that's very important, because when we see these bacteria growing in the blood culture that are contaminants, and sometimes we're not able to distinguish whether they're contaminant or real, and patients get unnecessary antibiotics, they stay in the hospital longer, they may receive unnecessary antibiotics, more testing. So there's a lot of downstream effects again of having high blood culture contamination rate. So in short, basically every blood culture draw for a culture, we should use the diversion device.
Yes, that would be fantastic. And that's what we are recommending for our laboratory practice.
Great. And our goal is to be less than 1%.
That would be fantastic. We're going to get there. We're so close.
Yeah.
We are so close, but we really want to be there on a regular basis too.
That's great. Thank you for all the work on that. The last thing I want to talk about is there's so many tests. Laboratory medicine is just exploding with new rapid diagnostics, molecular tests. And I'm not a lab expert. I use the lab to make decisions to help my patients to treat them. So when, let's say I hear about a new test, or a rep approaches me with a new test, what's the best way to kind of get information? Is this something reliable? Is it helpful? Should we be using this test? How can we use our lab partners in this?
Yeah, so diagnostic stewardship is a huge piece of where you can utilize your laboratory a lot more. We have lots of different experts in the laboratory. We have a whole team of pathologists. They're highly laboratory trained medical professionals. They're excellent doctors. But then we also have different subject matter experts in each of the departments that can weigh in on these new tests that are coming out. Now, it's really good to talk with the lab about these new tests, because there's lots of new technology out there. We love the new toys too. I promise. We do love this. But just because it's out there does not mean that we should be bringing it in. We look at things such as, when we bring this test in, how accurate it is, how specific it is. We also want to look at things like cost effectiveness to make sure that it's going to be good for patients, both inpatient and outpatient, because reimbursement is different for each of those. But also making sure that you're getting good results and actionable results for it too. So just because you're going to get a result from it, what are you going to do with it? And I know it's good information, and sometimes it's really fun to know, but sometimes you don't need all of that. So as an example, something like influenza A, we have tests for influenza A. We don't typically subtype that out to all the different flu A varieties that are out there, because the treatment for that patient is not going to be any different. For epidemiological purposes, it's good to know, but in our community health setting and, just trying to make sure our patients are well and they go home and don't make the rest of their family sick, we don't really need to know down to that.
And then if there are exceptions, like now we're talking about the avian influenza, and if we have a suspicion based on the risk factors, we can always partner with the lab, and you guys can guide us how we can send the sample to the state or CDC for further typing, or a reference lab.
Absolutely. And we have lots of partners within our reference laboratories, and they can help us with that. What we try to avoid is the testing of everybody where it's not appropriate for that. So those are the things that, it's really good to partner with our lab on that, to make sure that the test that you want to use really makes sense, to make sure that we're treating the patient the right way too.
That is very important. That is very important. I think we're just getting the conversation started about diagnostic stewardship. So thank you for joining us today. There's so many topics I want to cover, but to keep it short and concise, let's end this here today. But I'm really hoping actually you can join us some other time, or maybe bring some of your other team members, and we can continue this conversation.
Yeah, it's really important for the lab to get out there. We kind of try to stay in the background of things, but it's good for us to also be out there and just have these conversations and make sure everybody's aware that we're here as a partner for you and the testing and, you know, the needs that you have for patient care.
Absolutely. Thank you, Sarah.
Thank you.
Thank you.